Hello, welcome. My name is Scott Suko, and I'm the Executive Director of the Northeast Ohio Liver Alliance, and we're excited to invite you to our Liver Q&A webinar today. It's HCC Diagnosis and Treatment in 2021. A little bit of housekeeping before I introduce our Board President of the Northeast Ohio Liver Alliance and our speaker that will be presenting today. Throughout the webinar, if you have questions, please put them in there's a chat box or a question box, and I'll be monitoring those and then presenting those to the speaker at the end of today's webinar. Also, today's webinar is for educational purposes only. If you are a patient or a caregiver, please consider this education, but consult with your primary care doctor or your medical specialist for individual questions about your particular liver disease. So with that, let's go ahead and get started. I'd like to introduce our speaker today, Dr. Pierre Gholam, MD. He's with the University Hospitals Cleveland Medical Center, and in addition to his work there, he is serving as our volunteer board president of the Northeast Ohio Liver Alliance. The mission of the Liver Alliance is to promote health through education, advocacy, and research, and to support people living with liver disease in Northeast Ohio. Dr. Gholam, welcome.
Thank you very much. Thank you, Scott. Let me start my camera here. Yeah. And share my slides.
I love the glimpse of the screenshot. You can always tell brilliant minds because they've got a lot on there.
Yeah, I think that's either a good thing or a bad thing. I'm not really sure. But anyway, it is my pleasure to welcome all of you to this inaugural activity of our Liver Alliance. My name is Pierre Gholam. I think I know many of you, maybe not all of you, but many of you. And I'm thrilled to see that we have a fantastic attendance for this inaugural activity. As I will mention at the end, I hope that you will join us for future activities where we will also be presenting exciting topics related to liver disease, and we'll be announcing a full roster of both patient-oriented and healthcare practitioner-oriented activities for the upcoming calendar year, so stay tuned. The topic today is HCC, and the landscape of HCC has dramatically changed. So let's get to it pretty quickly because we have a fairly packed program. I think I threw Scott a curb by initially planning to present on both diagnosis and treatment of HCC, but then I realized it would literally take us 5 hours to do this. So we may do a diagnosis talk separately. This will focus almost exclusively on treatment, although there will be some epidemiology and a general disease state data at the beginning. So this very stark opening slide shows you that based on projections done from the rate of increase of HCC, hepatocellular carcinoma, or primary liver cancer in the US, this is anticipated to exponentially increase between now and all the way out to 2030. This increase is starkest in people aged 65 to 84. The left panel A is for males, the right panel B is for females, and you can see clearly that measured by rate per 100,000 person years, that rate is supposed to well over double by 2030, reaching about 10 per 100,000 reaching about 1 per 10,000 person years by then. The increase is not nearly as steep and may actually dip down for people aged 50 to 64 and is likely to remain flat for folks aged 35 to 49, probably owing to these folks having earlier disease and benefiting from advances in medical therapy, including cure of hepatitis C. But we know that the bulk of patients with HCC are in the 65 and above age group, and unfortunately, that's the group that's likely to experience the sharpest increase. This equally stark beginning to our talk reflects on the incidence of liver cancer between 1975 all the way out to 2017. This is measured as rate per 100,000 persons, and you can see in the blue set of dots that the rate of new cases is going to likely continue to increase, though we hope at some point it will plateau in the upcoming years, and the rate of death will also increase compared to 1975, but hopefully will plateau as many of the new exciting treatments that we're going to be focusing on. This will not all be gloom and doom. There's a lot of great positive new information about HCC treatment as this kicks in the upcoming years. So why do people get hepatocellular carcinoma, which I'll refer to as HCC from here on? The background that allows HCC to develop is a background of a diseased liver, either from alcohol-associated liver disease, which I'll remind you is now, bar none, the leading cause of liver disease in the US and Europe. Hepatitis B, which on a global scale is the leading cause of liver disease in HCC because of the large epidemic in Asia. Hepatitis C viral infection, which we've made great strides in treating with cures of almost every patient, but that continues to be a significant factor. And the, no pun intended, growing epidemic of non-alcoholic steatohepatitis or fatty liver, which continues to drive and will continue to drive in the upcoming decades the prevalence of liver disease. So an inflamed liver because of these or any other underlying liver disease can lead to hepatitis inflammation. Typically over decades of life, cirrhosis can ensue. And the background of cirrhosis allows for the development of hepatocellular carcinoma, typically at the rate of somewhere between 2 to 5% per year. So it is very likely that someone who survives cirrhosis for a decade or more will unfortunately develop liver cancer. And to put this in perspective, we estimate that in 2021, there will be over 42,000 new diagnoses of HCC. I'm sorry, 42,000 new diagnoses of primary liver cancer, of which 75% are HCC, and roughly 30,000 deaths attributable to HCC. Treatment of HCC, as those in the healthcare field, and I see many of you on our team, know very well, is a team sport. You do need multiple disciplines to collaborate in order to offer patients the best outcome. These include obviously a liver specialist, a transplant program for those lucky enough to benefit from the option of liver transplantation, a surgeon for those who need a resection, a medical oncologist who will assume the care, the primary responsibility for care for persons who have unresectable cancer, and very importantly, a pathologist who can make an accurate diagnosis in situations where it may not be obvious from imaging that the patient has HCC. To your right is a series of studies which you don't need to delve into in detail, but what they do say invariably is that a person who is under the care of what we call an MDT, a multidisciplinary team, has better survival, is more likely to receive a transplant, is more likely to be diagnosed early, which is a good thing, and that presentation in the context of a team actually often changes the diagnosis and the interpretation of pathology and hopefully improves the treatment plan to one that offers the patient the best outcome. HCC is unique among all cancers in that it doesn't only need to factor in the severity of the cancer, how far it's spread, how big it is, what grade it is, etc., but also very critically has to factor in how sick the liver is, because there are competing risks for death, which include liver cancer and also liver disease. And the tried and true method that we assess to make that determination is the Child-Pugh score. This includes 3 objective criteria that you get from blood work, bilirubin, albumin, and INR, and 2 subjective criteria, ascites and encephalopathy. These are graded on a 1 to 3 score, as you can see in this table. If you have up to 6 points, you have Child-Pugh class A. Your survival at 1 year is about 97%. If you have more than 7 points but less than 10 points, you have Child-Pugh B. your survival drops to about 70%. In CHOP-UC, the most severe form, where you typically have more than 10 points, reflects a very grim prognosis, where in the absence of the option of liver transplantation, life expectancy falls below 50%. One of the critical factors that play into what we treat patients with and how we treat them is the presence of varices in the esophagus. This happens because of increased pressure in the portal vein, what we call portal hypertension. And very critically, and I'll talk about this in our treatment section, treatment itself can exacerbate this, make it worse, and potentially put the patients at greater risk for variceal bleeding. Because not everyone on our call today is a medical oncologist. I apologize for the medical oncologists on the call who do this for a living every day. It's important to go over some definitions in order for you to better understand the outcomes of some of the studies I'm going to present. We consider a tumor to have experienced a complete response when it is, now you see it, now you don't. You look at a scan, you give a treatment, you look at the scan again in 3 to 6 months, there's no evidence of the tumor. That's a wonderful thing. We don't experience that very often in HCC yet, but hopefully the time is coming when that will not become an exception. But that's what a CR, a complete response, is. A partial response is when the tumor or tumors, sometimes more than one, shrink to less than 30% of their total greatest diameter. So a radiologist will measure the greatest diameter of all these tumors. If it's less than 30% than before, that's a PR, or a partial response. And if you add CRs and PRs, you get something called an objective response rate, or ORR. And if you add patients who have not changed over time, and for HCC, that is often a very good thing, you add that group of patients, what we call SD, or stable disease, and your total is what we call the disease control rate. That's every patient who has either not changed over time, has had complete shrinkage of tumor, or partial shrinkage of tumor. This is a very broad overview of where we stand in 2021. Unfortunately, the vast majority of people with HCC do not come to treatment with the option of cure. In fact, there are only 3 known ways to cure HCC. Surgical resection, known as an R0 resection, where a surgeon intends to remove the tumor with clean margins and with the expectation of a cure. Liver transplantation for those who meet criteria and are appropriate candidates, and radiofrequency ablation or microwave ablation, but that's really reserved to tumors less than 2 centimeters or equal to 2 centimeters in greatest diameter. Everything else is really non-curative at this point. Sometimes this is referred to as palliative, but I find palliative to be somewhat depressing in the context of treating a cancer that we're making great strides in improving outcomes for. So I'd like to call them non-curative. This includes systemic chemotherapy. That will be the bulk of everything we're going to talk about today. Radiofrequency ablation for other lesions, microwave ablation, embolizing therapies, which come in 2 flavors, chemotherapy type ablations, which are known as transcatheter arterial chemoembolization, or TACE or DEP-TACE, and radiologic embolization, known as Y90 radioembolization, of which there are 2 different brands that one could apply. There are some emerging therapies we rarely use, including irreversible electroporation or nanoknife. And then in developing low-resource countries, other treatments are applied with some great efficacy. We don't usually use those in the US, but these include percutaneous ethanol injection and cryoablation. So very briefly, radiofrequency ablation, by the way, the same applies to microwave ablation, is treatment where a radiologist applies a probe through the skin into the liver. It basically targets a tumor in the liver. A probe has prongs that come out of it once it is in the tumor. The radiologist then delivers heat through the form of radiofrequency energy or microwave energy through a device that is hooked up to the probe and basically fries this tumor. As you can see, there are challenges with this in that if the tumor is very large, you cannot realistically expect a good tumor kill. That's kind of the buzzword here. But if the tumor is small, you can very effectively destroy it and cure it, usually if it's less than 2 cm in diameter. Transarterial chemoembolization is a vascular procedure. A radiologist will gain access to the hepatic artery through different approaches. They will thread a catheter up into the hepatic artery and inject chemotherapy directly into the tumor. They will then occlude the feeder to the tumor with a combination of foams and coils. And so you have a dual chemotherapeutic, local, and embolic effect that effectively kills the tumor. This can be delivered through the form of beads, and these beads can be laced with either radioactive material, yttrium-90, or adriamycin. This is best reserved to solitary tumors that are large and can be targeted through a feeder artery. As you can imagine, if there are multiple tumors in the liver or if there's cancer outside of the liver, the efficacy of this intervention drops pretty significantly. But for the right patient who doesn't have metastatic disease or invasion into a large vessel, this is an excellent modality for therapy. And this very broadly summarizes to you our current state of understanding of how we should strategize and treat patients with HCC. This is known as the Barcelona Clinic Liver Cancer Staging and Treatment Strategy. I'm not going to focus too much on early stages. This is where someone is diagnosed very early. We don't unfortunately know how to do that very often in this country. We do a better job in Asia at this, but if someone has a very early lesion, resection or ablation is the way to go, and the outcome is excellent. If the tumor or tumors are still small and the liver function is very good, and the performance status of the patient is quite good, then transplantation for those that are not candidate for resection or ablation is an excellent modality. And if they're not transplant candidate, ablation can be used. A median overall survival of greater than 10 years can be expected, and certainly well over 6 years if you select appropriate candidates for resection or ablation. Chemoembolization, what we just talked about, is for bigger lesions that have not metastasized. There is a group of patients who have very, very advanced disease, are not candidates for transplant, and have very poor performance status. These patients, unfortunately, we don't know how to improve their quality of life or quantity of life at this point, and they do not have an allocated treatment. And the vast majority of the people we see, about 60%, have disease that has already invaded a blood vessel or has metastasized outside of the liver. And that is where the focus of our treatment is. This is the domain of systemic therapy or chemotherapy. And here you see that second-line therapies can buy you up to 13 to 15 months. But as you will see in the remainder of my talk, that is probably a pessimistic perspective on where we stand. So in 2007, the FDA approved Sorafenib as the first systemic therapy agent for HCC. It took us over 10 years to approve a second agent, Lenvatinib. And since then, we have had a rapid expansion of options, not only in first line for patients with HCC, with the approval of Atezolizumab and Bevacizumab in 2020, but also a number of treatments that were approved during these years in second line. Second line meaning once first line treatment fails, additional treatments can come in and hopefully add to the life of the patient and offer them good quality of life. The agents are listed here, and we will discuss them in detail. So Sorafenib, the drug that we've had since 2007, was approved. And pay attention to the numbers here, because I think if you want to be optimistic about HCC, this will give you great room for optimism. In 2006, this paper was initially reported, and it shows that Sorafenib improves median overall survival. Overall survival, self-explanatory, right? How long are you going to live if you take this therapy? From 7.9 months if you take placebo, that's the line in red, to 10.7 months if you take Sorafenib. This does not appear like a tremendous period of extra life, but certainly was hailed as a pretty dramatic improvement in outcome. A more modest in terms of time result was achieved in Asian patients through the study called Asia Pacific, but the magnitude of the effect was essentially the same. In 2017, the FDA approved a second agent called Lenvatinib. Both Lenvatinib and Sorafenib are what we call multi-targeted oral small molecular tyrosine kinase inhibitors. These are oral pills, small molecules that target different pathways known to affect cancer. For Sorafenib, most of that focuses around RAS and RAF. For Lenvatinib, the bulk of the therapeutic effect is derived towards the angiogenetic factors that drive tumors to vascularize and get blood supply. And these include vascular endothelial growth factor receptors 2 and 3, as well as PDGFR alpha and other pathways, including RET and KIT. So these drugs work through different pathways to reduce access to blood supply for the tumor, but since they affect blood vessels, they do have side effects that predictably can impact adverse events, including high blood pressure and other things we'll talk about in a second. And in fact, in this large study called Reflect, which basically pitted Lenvatinib versus Sorafenib, Lenvatinib was deemed to be non-inferior to Sorafenib, but pay attention to the numbers here. The median overall survival now is 13.6 months for Lenvatinib, and the same drug, Sorafenib, now has a median overall survival of 12.3 months. There are other things we pay attention to in cancer. One is called PFS, which stands for progression-free survival. This more than doubled with Lenvatinib versus Sorafenib. Progression-free survival is how long does imaging reflect a lack of progression of the tumor in someone who's alive with cancer. And a third parameter that improved over time was something called time to progression. That's how long it took a tumor to progress on subsequent imaging with a drug. And for Lenvatinib, it was about 2.5 times what it was for Sorafenib at 8.9 months versus 3.7 months. But again, bear in mind, when looking at overall survival, which is the point that the FDA had historically used to approve drugs, there was no inferiority between non-inferiority of Lenvatinib to Sorafenib, but there was no clear evidence of superiority. So this drug was then approved. All of these tyrosine kinase inhibitors, and many of you see patients who are on them on a regular basis, have a sort of a common theme of side effects. These are driven by vascular pathways, hypertension, proteinuria. There is a lesion on the hands and feet that can happen called hand-foot skin reaction, which can happen to patients, although at a high grade, they tend to be lower in number. And these agents are notorious for causing diarrhea, although a small percentage of patients, I think 4% for both Lenvatinib and Sorafenib, in this Reflect trial had a grade 3 or 4 side effect. Fatigue is also a cardinal sign of all TKIs, and about 4% in each arm of the study had severe fatigue, which can be debilitating in many of these patients. A very important breakthrough came in the past 2 years with the FDA approval last year of a combination of, this time not oral, but intravenous combination chemotherapy, a combination of Atezolizumab, which is an immuno-oncology drug. If you are familiar with the revolution that immuno-oncology has created in cancer, this agent, Atezolizumab, is part of that. It is a PD-L1 inhibitor, and it basically inhibits ligands that allow cancer to escape the immune system. By doing so, it allows the immune system to effectively fight cancer and reduce its ability to grow and spread. The second agent in combination is a drug that we've used in cancer for a long time. It is a monoclonal antibody against VEGF, a vascular acting antibody called Bevacizumab. And these drugs were used in combination and compared to Sorafenib, which was up until then the standard of care in first line in this study called Imbrave 150. These drugs are given in an infusion suite, in a chemotherapy infusion suite every 3 weeks. They were compared to Sorafenib given at the usual dose, 400 milligrams twice a day, every day. This was a drug given to patients who had locally advanced or metastatic cancer. So you have to understand the context in which these drugs were deployed and how they in turn were used to treat this fairly advanced group of patients. The primary endpoints were overall survival, how long were you going to live if you took this, and what your progression-free survival was. How long was it going to take for a tumor to evolve over time under radiological examination, or how long were you going to be free of progression in a patient who took Atezolizumab versus Sorafenib. And treatment was continued until you had intolerable toxicity or there was clear evidence that cancer had progressed on imaging. And again, pay attention to the numbers here. Remember, we started out with 10.7 months in first line, the median overall survival, and I don't know if you see my arrow here, but the median overall survival now in first line for Atezolizumab, as it is affectionately known, was 19.2 months. So we started at 10.2 months, we're at 19.2 months. And Sorafenib, remember the drug that gave a good result in 2007 of 10.7 months, is now at 13.4 months. Now this requires a little bit of a pause. One might wonder why the improvement, not only in this new regimen, that's wonderful and welcome, but why would the improvement happen with Sorafenib also? And the answer is, over the decade that had gone by, when patients would fail Atezolizumab or Sorafenib, they would have other options in second lines that their medical oncologists or hepatologists would switch them to. And in a study, they factor in that time lived above and beyond when the patient stopped responding to the treatment. So overall survival is a very wonderful way to assess what the patient's outcome is. I don't take anything away from it, but it becomes a little bit murky as more and more treatments come along, because you have to factor in what the patient takes after the end of that particular treatment, what we call subsequent therapies. But nonetheless, this is a great slide to show to a patient and explain what you're trying to do. At 6 months, 85% of patients were still alive on Atezolizumab. At 12 months, 67%, and at 18 months, 52%, and that tails down from there. But clearly a very remarkable improvement over a relatively short period of time for our patients with pretty advanced HCC. We're not talking about patients who are looking for a cure here. We're talking about patients really mostly with metastatic disease. And if you look at progression-free survival, this improved from 4.3 months with Sorafenib to 6.9 months with Atezolizumab. And you can see the durability of the response in the Kaplan-Meier curves below. 24% of patients had a progression-free survival by 18 months, and about half of them at 6 months. This just reflects some of these parameters I mentioned to you earlier. About 8% of patients had complete response. Please focus your attention on the first two columns. The second two columns are probably not that important. They basically reflect a different way of measuring the same thing. Very rare complete responses with Sorafenib. About 22% of patients had shrinkage of tumors on Atezolizumab. Stable disease was achieved in 44% of patients. A disease control rate of 74%, and progression of disease happened in 19%, with a median duration of response of 18.1 months. So I think just pausing and thinking about this alone, clearly I think our ability to care for patients in the first line over a relatively short period of time has increased quite dramatically. This reflects adverse events. Every drug has adverse events, and these are no exception. You'll notice that for Sorafenib, some of the usual suspects are more likely to happen. More adverse events are likely to happen, including diarrhea, hand-foot skin reaction. For some, obviously, you would not see with Sorafenib. So Sorafenib is not infused, so infusion-related reactions in about 10% of patients with Atezolizumab, and none, obviously, with Sorafenib. And some are somewhere in the middle. So both drugs can give you hypertension, primarily because of Bevacizumab, which is a vascular endothelial growth factor, and some are just about a wash. It is important to point out that because Bevacizumab affects pressure in the portal vein, in the portal system, and potentially in the varices in the esophagus and other parts, there was an effort to mitigate risk of bleeding by mandating an endoscopy within 6 months of initiating treatment and trying to mitigate bleeding through therapy. The upper GI bleeding rate for Atezolizumab was 7% versus 4.5 months, which is actually not very different from what you typically see with Bevacizumab. But that obviously factors in a group of patients which had good liver therapy, good liver function. These were patients who had Child-Pugh liver function, and therefore their risk of bleeding, in addition to the mitigation effort done here, would have been lower than someone who we see with ascites and hepatic encephalopathy and some of the complications of liver disease, which would have Child-Pugh cirrhosis. Atezolizumab, in addition to awakening the immune system to fight cancer, just awakens the immune system in general. And so there are clearly groups of patients that are not candidates for this. Organ transplantation would be one. If someone has had a transplant, this would not be a good drug to give them because of the potential for inducing acute cellular rejection. If you have rip-roaring autoimmune hepatitis or horrible autoimmune disease of any kind, clearly this is not a good option for you. And there is the potential for this drug to de novo cause immune-mediated colitis, which can be severe, pneumonitis, hepatitis, and endocrinopathies. Bevacizumab has been associated in rare cases with GI perforation, so surgery basically has to be spaced out away from receiving this therapy. We mentioned the concern about variceal bleeding. Some patients in the study can develop uncontrolled hypertension and proteinuria. Again, a byproduct of if its vascular side effect is a potential problem. There have been patients related to its vascular impact that could develop congestive heart failure. So all of these are important points to remember when initiating this therapy. This is, by the way, not the end of immunotherapy at all by any means. In fact, there are there are at least 5, but I've listed 2 here, combinations of drug. These are combinations of a PD-1 or PD-L1 inhibitor similar to Atezolizumab that are being trialed right now in combination with a different mechanism of tweaking the immune system so that it can more effectively handle HCC. That's a drug called Tremelimumab, which is a CTLA-4 inhibitor, and the combination of durvalumab plus tremelimumab is currently being trialed with Sorafenib. We've already had some press releases about this. I'm not going to divulge details because we don't have them, but certainly something you may hear more about soon. Nivolumab and ipilimumab is also a combination of a PD-1 and a CTLA-4 inhibitor, and this has been compared to Sorafenib in this Checkmate 90W study. And why not combine a TKI and an immunotherapy? So there are studies ongoing, one called LEAP-002 for Lenvatinib with pembrolizumab, the other for Cabozantinib with Atezolizumab. Both of these have data sets that have matured, and we'll be hoping to hear about them at ASCO GI in the coming 2 months. And both are comparing these agents to established standards of care, including Lenvatinib and Sorafenib. So what happens after patients fail first-line therapy? I hate to use the word fail. A colleague who's a medical oncologist always says, you should never say to a patient you failed therapy. You should tell them that therapy failed you. You did not do anything to fail therapy. I think that's a good way of looking at it. But these treatments are not cures for cancer, so there are options available to patients once they stop responding to Atezolizumab, Sorafenib, and Lenvatinib. And these include FDA-approved combinations, including Regorafenib, Cabozantinib, Ramucirumab, Pembrolizumab, and the combination of Nivolumab, Ipilimumab. You'll notice Nivolumab under an asterisk here. This was approved, was FDA-approved in second line, but in April 2021, BMS voluntarily removed the indication for it after a determination that the indication may not be appropriate in that set of patients. So I will not be discussing that next. So pembrolizumab is another PD-1 immuno-oncology drug. This is an IV drug that's given every 3 weeks. This was compared to placebo in second line because we did not at the time have an established second line therapy. These are Child-Pugh patients, good liver function. They had to have multiple tumors, although they may not necessarily have needed to be metastatic, but the bulk of the patients in the Keynote 240 study did have metastatic disease. Patients had to have a very good performance status, had to be able to perform activities of daily living for the most part. PFS, progression-free survival, and OS were the main endpoints to look at. And when you look at the details, you remember this is second line, so this is not the first stab at therapy. So we're talking about a more experienced, more advanced group of patients. Pembrolizumab offered a median overall survival of 13.9 months versus placebo at 10.6 months. If you look at progression-free survival, it was slightly higher for pembrolizumab compared to placebo at 3.3 months versus 2.8 months. And based on that, pembrolizumab was approved in this group of patients, even though technically it failed to reach a pre-specified level of statistical significance for OS and PFS. And that indication remains on the books till today. So it leaves this drug as a potential option in second line for patients. Another drug combination of two immuno-oncology drugs, nivolumab, a PD-1 inhibitor, and ipilimumab, a CTLA-4 inhibitor. So two immuno-oncology drugs at the same time were trialed at 3 different doses. I will, for the interest of the non-oncologist here, point your attention to exclusively the blue line. That is known as Nivo-1 Ipi3, a higher dose of ipilimumab, which carries with it a higher degree of adverse events, but potentially more efficacy. These drugs are given every 3 weeks. This is an open label trial of 3 different doses. And if you look at the Kaplan-Meier curves to your right, this is median follow-ups up to 47 months. You'll notice that there's a pretty sharp difference in median overall survival between Nivo-1 Ipi3 every 3 weeks and the other 2 options following it. 22.2 months in second line for Nivo-1 Ipi3. The other 2 are 12.5 and 12.7 months, and in the end were not approved in second line for treatment. The Nivo-1 Ipi3 regimen is the one that we have currently in second line. Again, when you give immuno-oncology drugs, you have to pay attention to immune-mediated side effects. Again, focus your attention exclusively on the blue column, Nivo-1 Ipi3. In particular, the last line where it says hepatobiliary, this is basically code for autoimmune hepatitis. There were some patients, 6%, that developed autoimmune hepatitis, but there were others that developed autoimmune colitis, about 6% was severe, and a variety of other skin and endocrine manifestations, all related to immune-mediated therapy. There is literally 10 slides that go over how we manage immune-mediated side effects for all these different immuno-oncology drugs. And there are parameters for when to initiate steroids, when to stop steroids, what else to give for maintenance, and when to decide to bail on the drug completely. And I will not bore you with these other than to tell you that this is an area that's very closely followed by treaters, and certainly we need to monitor these patients closely. Fortunately, severe immune-mediated effects with all of these immuno-oncology drugs remain relatively uncommon. This actually tells you, is a very helpful hint to when you might expect specific side effects of immune-mediated therapy. This applies pretty much to all of these, but here specifically for Nivo and Ipi. And you can see that many of these happen early, typically within 4 to 6 weeks for things like skin rash. Some things happen a little bit further out, including endocrine, typically notorious for happening at any time during therapy. Some peak typically within 10 to 14 weeks. That's the pneumonitis, which can be very severe. And some can happen early, including colitis, which can happen anytime between week 4 to 10. So the astute treater should be very familiar with this and know how patient symptoms might reflect toxicity from these particular agents. This is a detailed breakdown of how you manage these. I'm going to skip that unless someone has a high level of interest in managing these. We call them immune-mediated adverse events. So immune-mediated adverse events, but certainly there is a mechanism for observation supportive care for mild withholding therapy if toxicity happens after an initial mild event, stopping therapy if there's a serious medically significant event, and obviously for urgent intervention and immediate stoppage and discontinuation for life-threatening consequences. A second line that is approved in a second drug that is approved in second line is a drug called Regorafenib. Remember Sorafenib, which I started with earlier. This is literally a drug that only differs from Sorafenib by having a fluoride ion attached to it. It's a fluorinated Sorafenib. This drug was studied in second line compared to placebo. This is given on days 1 to 21 of a 28-day cycle at the dose of 160 milligrams once a day. And the usual patients are the ones that are being looked at. Good performance status, mostly patients with metastatic disease, and this was a worldwide study. And this does not show very well, so I apologize, but I will read that to you. In this research study of Regorafenib, the median overall survival was 10.6 months versus 7.8 months for placebo. This should sound familiar because Sorafenib did exactly the same thing, but that was in first line. That was before patients received any therapy. And there was a doubling of progression-free survival in this quite advanced group of patients. The overall response rate was 10.6% versus 4% for placebo. And there was pretty good disease control rate at 65% versus 36% for placebo. Again, this drug has almost the same profile of adverse events as Sorafenib: hand-foot skin reaction, hypertension, diarrhea. All the usual suspects are here. In a subset of patients, they can be at an advanced grade, for example, 13% hand-foot skin reaction, but certainly things that the astute Sorafenib treater should be very familiar with and able to manage. Ramucirumab, we're almost at the end here, so we're close to wrapping up. Every single FDA-approved therapy in first and second line as of November 9, 2021, is a monoclonal antibody against VEGF. This is a drug that was studied initially for a broad group of patients. It turned out not to be effective for most patients, but for those who have an alpha-fetoprotein, which is a marker for cancer, greater than 400, there was a signal that the drug would be effective. And so a REACH-2 study, the REACH-1 study was the first one which did not turn out to be positive, exclusively looked at these patients with an AFP greater than 400. And lo and behold, in that subset of patients, there is an efficacy signal with a median overall survival of 8.5 months versus 7.3 months. You'll notice the numbers here are much lower in terms of overall survival, but that's because that's second line, right? This is a patient who's already experienced treatment in first line and is looking for a second line option. Clearly, there are side effects related to vascular pathways. Again, high blood pressure in about 12% at a high grade, proteinuria, nausea, ascites, diarrhea, and fatigue, which of course is a cardinal symptom of cancer in general. Discontinuations in about 10%, dose adjustment in about a third of patients, and a small number of patients that died due to a TRAE, which stands for treatment-related adverse event. And last but not least, the FDA approved almost 3 years ago a drug called Cabozantinib, which was already FDA approved for other indications, including kidney cancer and more recently differentiated thyroid cancer, for the treatment of HCC in those previously treated with an agent, Sorafenib typically. This is another oral multi-targeted TKI. It targets vascular pathways, but also some pathways that other drugs typically don't target, including MET and AXL, which play a role in how drugs metastasize. This may have something to do with how the drug works in later lines, because that's when this becomes important. The starting dose of this is 60 milligrams once a day, and this was compared to placebo. Again, remember, this is after patients had received one therapy. In fact, unique in the Celestial trial, where patients who could have received more than one therapies, 2 therapies, and in some cases 3 therapies were also included, including I think about 8% who had already received immuno-oncology therapy in the past. The primary endpoint was overall survival. This basically breaks down all comers, including those that did not receive Sorafenib but received something else. And if you actually take all comers, the median overall survival was 10.2 months versus 8 months. a significant improvement in progression-free survival from 1.9 months was placebo to 5.2 months. But and a response rate in the setting, which is obviously expected to be lower at 4%, and a stable disease of 60% versus 33%. If you actually look at side effects, they are very, very similar to Lenvatinib, Sorafenib, and Regorafenib, the other TKIs. Diarrhea at a high grade in about 10% of patients, hand-foot skin reaction in about 17%, hypertension about 16%, asthenia in about 7%. But if you exclusively include patients who only got one line of therapy, so this is not the patient who got 2 or 3 lines of therapy, that line of therapy by definition would be Sorafenib, right? You had to have Sorafenib, and you could have something on top of it in second line. The actual overall survival was 11.4 months versus 7.7 months. So a reflection of if the patient had taken Sorafenib and you were considering giving this in second line, this would be a reflection of what you would more or less expect. 11.4 months versus 7.7 months for a hazard ratio of 0.74. So we've pretty much covered every FDA-approved drug in first and second line. I think our take-home points are the following. The prognosis of advanced unresectable cancer is now in the years, not in the months. This is wonderful news. We no longer have to tell patients that they would not realistically expect a decent life expectancy and that they would have to basically take care of their affairs over a short period of time, because the prospects of surviving in first and second line has improved dramatically. In first line, treatments in the appropriate patient can yield up to 19 months of survival with less side effects. And in second line, many therapies extend life even further. Many other approved therapies, and I stayed mum on this, but I anticipate even in the next 12 months, we'll have more approved therapies that will hopefully be less adverse event heavy and extend life. One point that remains somewhat unclear is whether we can combine things like TACE or Y90 with systemic therapy in order to improve the outcome of patients. Studies that have used some of the first agents approved were not definitive and mostly negative, but this is being revisited now that we have better agents. And so we might have an answer as to whether combination therapy between drugs and procedures might actually make patients' life better, I would assume, in the next 3 years. And last but not least, please visit our website, the www.liveralliance.org. We look to your active participation, not only as attendees of our webinars, but participants in our activities on the various committees that we'll be doing to, we'll be organizing to improve the advocacy landscape for persons with liver disease in Northeast Ohio, to educate more, and to certainly promote research, meritorious research in the state. I'll remind you, there are 3 outstanding upcoming webinars, one by Dr. Naeem El-Khoury about fatty liver disease, a very popular topic. November 30, we have Marty Cohen, who is my partner and colleague here at University Hospitals. He's going to talk about viral hepatitis. And last but not least, I think it'll be a treat. We'll have Bill Carey and Erica Harrington, who will talk about the hopefully not too elusive goal of US elimination of viral hepatitis and some of their thoughts and the evidence towards this. And I thank you very much and look forward to taking any questions that you may have.
Excellent. Thank you so much, Dr. Gholam. And it looks like you are right on the mark for the timing, and there are no questions at this time. So let me just make a couple announcements where we give folks a chance if they have a question to put it through. Folks will be receiving an evaluation via email. Please fill it out and include in that any topics for future webinars that you'd like to see discussed by members of the board or experts here in the Cleveland, Ohio area. And let's see here. Also, today's webinar has been recorded. It will be uploaded on our YouTube channel and then shared on the website as well. So consider it an ongoing resource, not just for today's hour of learning, but in the future, if you want to go back and refresh, it will be available to you on our website or the YouTube channel. And with that, I think we've really met the mark, Dr. Gholam. Any parting words for folks?
No, I'm very happy about the level of engagement on this initial webinar. I'm hoping that we'll have even more folks join us for some of the very timely and very relevant clinical issues that we'll be discussing soon. I also want to let everyone know that although this is a suitable medium to communicate safely with folks, we are not particularly thrilled with online communication channels, as I'm sure you all are, and are looking to expand our activities to in-person. This not only includes educational activities, but in-person fundraisers, fun things to do, not only with our healthcare community, but also with our patient and patient advocate community, which more on that I'm hoping in the next few. If you have friends, colleagues, interested patients or advocates who want to join us, please visit the website and register. So that's the only way that Scott, Sue, and their team know that you are interested and can start sending you invitations to some of our activities. We are a nascent and new organization, so we don't have endless databases of people who are engaged, and we'd like to not leave anyone behind. We want everyone to be an active participant.
Excellent. Well, thank you very much and have a great rest of the day. Bye now.
Thank you. Bye-bye.